Can we start, sir?
Yes.
Thank you. Thank you very much. Good evening, everyone. A happy Diwali in advance to all the dignitaries present today for our 9th Tuesday Techs. Every month on 3rd Tuesday, Indian Academy of Pediatrics, along with Women's Wing, gives platform to 6 new young speakers from different areas of Maharashtra. And I sincerely thank Dr. Amol Pawar sir and his team for helping us out to find these gems from the peripheries of Maharashtra. Today, we have with us 6 speakers, which are very new and very enthusiastic from periphery of our Maharashtra. With that, we have 2 experts with us. We are very well known in their field. With that, before giving introduction of the expert, I would like to invite our president, Dr. Hemant sir, to have few words. Hemant sir, over to you.
Thank you, madam. Good evening and namaste to all the respected dignitaries on this Zoom dais and our all excellent 6 speakers, Dr. Neha Singh, Dr. Shraddha madam, Dr. Poonam madam, Dr. Richa madam, Dr. Naval sir, Dr. Sucheta madam, as well as our 2 excellent dynamic judges, Dr. Meena Sheikh and Dr. Ganesh Kulkarni sir, and all the participants all there on the Zoom dais, as well as all MahaIP YouTube viewers seeing this episode. Hearty congratulations to MahaIP Women Committee. This was the idea which was started in February, and they promised to give the 9 episodes of Tuesday Takes. So excellent, excellent all 9 episodes. We had 54 topics, 54 speakers, 18 moderators, 18 judges to carry out all these 9 episodes. And so we had a wonderful 9 episodes of Tuesday Takes. This journey, and as written on the flyer also, this journey we started in February, and today we are with the 9th episodes. The hearty congratulations to the chairman and co-chairman of this MahaIP Women Committee, as well as 10 zonal committee members of this MahaIP Women Committee, to do the wonderful work and to search the speakers across the Maharashtra state and to provide all the information regarding them. And as well, heartfelt thanks to Dr. Neha Singh to draft all the messages of all Tuesday Takes, excellent appealing messages, as well as Dr. Vishal Raut from Raigad to make all the flyers, excellent appealing flyers, as well as total MahaIP team, Dr. Amol Pawar, Dr. Jay Bhandarkar, Dr. Vinayak Patil, and Dr. Mohan, all cooperating with us to have this all excellent 9 episodes. And probably this will be one more wonderful episodes. We are looking forward to the wonderful episode of this Tuesday Takes. All the best wishes to all 6 speakers, and wish each one and everyone a happy learning. Thank you very much.
Thank you very much, sir, for very kind words towards the Women's Wing. Thank you very much. Now I would like to invite our secretary, Dr. Amol Pawar sir, to have few words. Over to you, sir.
Thank you, Reena. सर्वप्रथम मी आजचे जे एक्सपर्ट्स आहेत, डॉक्टर गणेश कुलकर्णी सर, सिनियर पीडियाट्रिशियन, पास्ट एक्झिक्युटिव्ह बॉडी मेंबर, सेंट्रल IIP, आणि स्टालवार्ट फ्रॉम महाराष्ट्र IIP. So welcome Dr. Ganesh sir. Then second expert Dr. Meena Sheikh sir, जे PICU मध्ये अतिशय एक्सपर्ट आहेत. PICU व्हेंटिलेशन वर्कशॉप, पूर्ण जी PICU चॅप्टर आहे त्यांच्या मेहनतीने तो उभा राहिलेला चॅप्टर, आणि प्रत्येक कॉन्फरन्स किंवा व्हेंटिलेशन वर्कशॉप संदर्भात पाल्स असो वगैरे सर्व त्यांच्या मेहनतीने ते काम करत असतात. महाराष्ट्रातले जे 4-5 लोक आहेत ते त्या चॅप्टर मध्ये नेहमी पुढे राहून काम करत असतात. असे डॉक्टर शेख मीना सर, सिनियर पीडियाट्रिक इंटेन्सिव्हिस्ट, मुंबई. तर त्यांचेही मी या प्लॅटफॉर्मवर त्यांना वेलकम करतो. तर डॉक्टर हेमंत गंगोलिया सर, बाकी सर्व जे महाराष्ट्र IIPचे आता जॉईन झालेले डेलिगेट्स, आणि या सर्वांना मी या प्लॅटफॉर्मवर वेलकम करतो. ही आयडिया जी MahaIP वुमन कमिटीची को चेअरपर्सन आणि चेअरपर्सन या दोन्हींनी मिळून ही आयडिया पुट फोर्थ केली प्रेसिडेंट सरांसमोर आणि पूर्ण MahaIP टीम समोर, आणि त्याला अनुमोदन देऊन आम्ही ही त्यांना मान्यता देऊन पूर्ण पॅट्रॉन्स, वुमन कमिटीच्या पॅट्रॉन्स स्वाती भावे मॅडम असो, देन संध्याकाळचे मॅडम असो, किंवा ज्या झोनल मेंबर्स आहेत 10, त्या सर्वांनी मिळून पूर्ण 9 एपिसोड्स मध्ये स्पीकर्स वगैरे सिलेक्ट करण्यासाठी 1-to-1 कॉन्टॅक्ट करून त्यांनी स्पीकर सिलेक्ट केले आणि अतिशय छान पद्धतीने पूर्ण 9 महिने हा कार्यक्रम 6 स्पीकर सहित व्यवस्थित, जे कॉमन पिडियाट्रिशियनला ऑफिस प्रॅक्टिस मध्ये जे काही इनपुट्स देणं गरजेचं असतं, प्रत्येक टॉपिकवर, प्रत्येक पेशंटसाठी नवनवीन जे टॉपिक असतात त्यावर ते इनपुट्स, टेक होम मेसेजेस अतिशय चांगल्या पद्धतीने दिले गेले सर्वांकडून. मी आजही आजच्या 6 स्पीकर्सला तीच विनंती करेल की तुम्ही टेक होम मेसेजेसवर अतिशय चांगल्या पद्धतीने भर द्या, म्हणजे जेणेकरून आता झूम प्लॅटफॉर्म फुल झालेला आहे. आता आपण प्रत्येक जवळजवळ 9 पैकी 6 ते 7 जे वेबिनार झाले आपले हे ऑनलाईन, तर प्रत्येकाला आपण MMC पॉइंट्स ग्रँट केले. त्यामुळे झूम प्लॅटफॉर्म पहिल्या 5 मिनिटाच्या आत, म्हणजे प्रेसिडेंट सेक्रेटरीचे स्पीच संपत नाही त्याच्या आधीच 3-4 मिनिटातच तो पूर्ण 100चा प्लॅटफॉर्म पूर्ण व्हायचा. आणि बाकी युट्यूबवर पण बरेच लोक जॉईन आहेत, तर त्यांनाही मी धन्यवाद देतो की तुम्ही जॉईन झालात. आणि स्पीकर्सला प्रत्येकाला ऑल द बेस्ट देऊन मी माझे 2 शब्द संपवतो आणि प्रत्येकाला हॅपी लर्निंग सांगतो. धन्यवाद.
Thank you very much, sir. Now we will introduce our first speaker, first expert, which is very well known as a pediatric intensivist from Mumbai, Dr. Sheikh Minaz Ahmed, sir. Sir is a lead intensivist PICU NICU, Lilavati Hospital and Research Center, Mumbai. Sir is guide to DNB pediatric postgraduate students, medical teacher. Sir is a faculty for many workshops like ACPP, BPIC, COVIN, COPP, ECD, EPIC, GEM, Picnic, NTCP, WAR, TASK 24/7 for 20 problems pediatric critical care. We are really proud of you, sir. In addition to above all, sir is having 25 plus publications, including books and chapters. We are very fortunate to have you as an expert, sir. Thank you very much for accepting our invitation.
Thank you, Reena.
Thank you, sir. Sir is going to moderate initial three cases. To introduce our next expert, I would like to invite my colleague, Dr. Swati. She will introduce our next expert, Dr. Kulkarni, sir. Swati, over to you.
Yeah, thank you, ma'am. Good evening, everyone, all the honoraries, office bearers, and all the delegates. It's a wonderful gift to encourage others to achieve greatness. So our today's second expert is Dr. Ganesh Kulkarni, sir, from Aurangabad. Sir is the Director, Chief Consultant, and Pediatric Intensivist at Sanjeevani Children's Hospital, Aurangabad, from last 22 years, which is a renowned tertiary care center in Marathwada region. And sir is the great academician and coordinator for postgraduate divisional quiz also, and national coordinator for STAMP and UIIP. Sir is the postgraduate teacher for DCH at Sanjeevan Children's Hospital, Aurangabad, and faculty for state as well as national conferences. Welcome, sir. Over to you, Reena ma'am.
Thank you. Thank you very much, Swati. So we are proceeding further with our first speaker. As we all know, these 6 speakers are from 6 different zones of Maharashtra. So today's opening batsman, our first speaker is from Mumbai Konkan Zone, Raigad IIP branch member, Dr. Neha Singh. She is going to talk on fontanelles. She is consultant pediatrician and neonatologist, editor Maha IIP 2021-22, EB member and editor Raigad branch 2020-22, having special interest in child growth and development, vaccines and hematology. I welcome you, ma'am. Dr. Neha, ma'am, over to you.
Thank you, Reena, ma'am. Good evening, everyone. First of all, I would like to thank Team Maha IIP and Team Maha Women's Committee for giving me this opportunity. The topic given to me is fontanelle. Friends, while examining head of an infant, what do we look for? We look for the shape, head circumference, soft tissue abnormalities, fontanelles, and sutures. The skull is made up of 8 bones, and the area where the bones join together are called sutures. These are fibrous septa, and these sutures are not joined together firmly at birth, allowing the head to change shape when they pass through the birth canal. The 4 sutures are sagittal, coronal, frontal, and lumboid. Sagittal is in between 2 parietal bone. Coronal is in between the parietal and the frontal bone. Frontal suture is in between the 2 frontal bones, and lumboid, it's in between the occipital and the parietal bone. There are in an infant, the space where the 2 sutures join form a membranous covered soft spot called the fontanelle. And there are 6 fontanelles at birth: anterior, posterior, 2 anterolateral sphenoid fontanelle, and 2 posterolateral pair of mastoid fontanelles. The anterior fontanelle, it is the largest and most important fontanelle, rhomboid in shape. It is present in at the junction of the coronal and the frontal suture, and it is present at the vertex of the skull. Average diameter is 2.1 into 2.1 centimeter. A small fontanelle is suggestive of IUGR or craniocentesis. Usually it closes at 7 to 19 months of age. Early closure conditions are
Just a minute, Dr. Neha. Somebody has joined from
two devices. Just carry on, I think so.
early closure of the anterior fontanelle. The conditions are craniocentosis and primary microcephaly, while delayed closure of the
Dr.
anterior.
Neha, just a minute. Have you joined from the 2 devices yourself?
No, who is the one person who is speaking is joined by 2 devices. Who is speaking that? Please mute yourself. You have joined by 2 devices.
No, sir. Neha ma'am, there is no double voice of Neha ma'am.
नाही मॅडमचा नाही आहे पण दुसरं कोणतरी बोलतोय त्यांनी डबल डिवाइस. ठीक आहे, कॅरी ऑन नाउ. नाउ इट्स ओके.
Please carry on.
Delayed closure of the anterior fontanelle, there are many conditions, but I have listed few important. These are congenital hypothyroidism, hydrocephalus, IUGR, malnutrition, rickets, hypophosphatemia, achondroplasia, Down syndrome, congenital rubella, and congenital syphilis, and many more. Posterior fontanelle. It is present at the point where the lumboid and the sagittal sutures unite at the junction of occipital and the parietal bones. It is triangular in shape. At birth, it is 0.5 into 0.7 centimeter. It usually closes at 1 or 2 months of age. Delayed closure may be due to Down syndrome. Other fontanelles, we don't examine them because they fuse in the utero. Normal fullness is seen. Normal fullness is seen in healthy infants when they cry or they are held upright. They are versatile in nature, but when they are constant in all position and there is no pulsation, it is considered true bulging. And the conditions associated are intravascular hemorrhage in neonatal period. Others are increased intracranial pressure, hydrocephalus, intracranial tumors, meningitis, encephalitis, subdural hematoma, pseudotumor cerebri, and many more. A slight depression is common in normal infants, but a slightly depressed relative to the fontanelle and the parietal bone is sunken anterior fontanelle, and it is a sign of dehydration in infants. The head can be also examined for shape, circumference, soft tissue abnormalities. The shape is transiently deformed at birth due to the molding, that is overriding of cranial bones, and excessive molding indicates obstructed or prolonged vaginal delivery. It usually disappears in few days. The various head shapes, I have shown the various head shapes here. Head circumference, it is a very important thing, and it is an indirect indicator of brain growth, and we should always note down the head circumference of the child at each vaccination visit till 2 to 3 years of age, because the brain growth completes by 3 years, and further increase in head circumference is due to thickening of the calvarium. Less than 3rd percentile head circumference is due to macrocephaly and craniocentosis, and more than 97 percentile is due to hydrocephalus, familial macrocephaly, rickets, chondrodystrophies, intracranial tumor. Soft tissue abnormalities. These are due to the cranial injuries. We have seen the caput hematoma, caput secundum here in the photograph, and the others are skull fractures and intracranial hemorrhage. Thank you.
Yeah. Good evening, friends. Am I audible?
Dr. Minashik sir, have you joined with two devices?
Not at all. No.
आपके end से problem है.
Sir,
Don't-
have you joined YouTube also?
मीनाक्षी सर आप यूट्यूब से भी ज्वाइन करेंगे. हाँ अभी when you are muted na Minashik sir, we are not hearing any echoing and any double voice. So probably whether you have joined by YouTube also you have.
If you have joined, just make it mute, sir.
हाँ अगर join है तो एक mute कर दीजिए आप उसको.
YouTube को.
You're talking about.
सर आप दो जगह से जॉईन हुए क्या मीनाक्षी सर?
नाही.
ते नाही दुसरं कोणीतरी चेक करा ना पल्लवी मॅडम.
नाही सर, कुणाचंच voice चालू नाही. आपणच बघतो.
ते अनम्यूट केल्यानंतर आवाज
डबल व्हॉइस बंद
होऊन
होतो.
जातं त्यांचं.
Anyway, I'll do one thing. Do you want to rejoin?
रिजॉइन के लिए सर जगह नहीं है, सब फुल है. अभी बोलिए.
नाही या सर.
अभी
नाही सर या
अभी
तुम्ही
बोल-
परत जॉईन करून देते. शेख सर तुम्ही जॉईन व्हा, मी तुम्हाला इन करून देते. जॉईन
जस्ट जॉइन ॲज लीव अँड जॉइन अगेन इमिजिएटली 30 seconds.
तोपर्यंत आपण you will just ask.
नेहा इट वॉज नाईस प्रेझेंटेशन.
डॉक्टर अमोल जोपर्यंत नेहा
Yes, sir.
जेव्हापर्यंत
Well.
आपलं आपण वाट बघतोय ना मीनाक्षी सरांचं, लेट अस टेक द
sir.
कॉमेंट फ्रॉम डॉक्टर गणेश कुलकर्णी फॉर हिज ओपिनियन
Yes,
ऑन
sir.
दिस एपिसोड्स.
गणेश सर.
Hello.
Yes, sir.
Hello.
Audible.
Am I
You are
audible?
audible.
Am I audible?
Yes, sir. You are audible. You are audible.
Yeah. Thank you, sir. I was waiting for this opportunity to be here on this platform because since last so many months I was so excited to see the programs that you all are conducting. This is amazing. This is terrific. In fact, this reminds me my beginning years of IIP when I was a shy guy and I always wanted to come on the dais and present something, but that time it was so difficult. No one gave us a chance, and we never thought of that someone would come up and tell us, "Yeah, come on and do something, present something." But this is a kind of a dais that you have prepared, and you are working so hard on it. And I see the enthusiasm of all the participants also. The way she has presented, this is amazing. This doesn't look like she is a beginner. She looks like that she has presented it so many times before. So I really congratulate you. This is how I think academy will grow with academics actually. And to me, I always feel that नाम मेरा गणेश है लेकिन विघ्नहर्ता तो अमोल ही है. No, he has become kind of for every problem he has a solution. He is a person who probably is the next Modi, or I would say, because he has an answer to every question.
अजिबात नाही सर.
What the words are pretty short when I come and pray. All these women wing delegates and organizers, they are really awesome. They're really awesome. I'm really scared now. We all males would have to sit on a backstage now. The all are running so forefrontly now.
Yes.
Congratulations. Evan sir, hats
Thank
off.
you.
This is one of the finest presidency I have ever seen since last 25
Yes,
years.
sir.
I'm an active, being active in IIP so many years.
Yes,
Hats
sir.
off.
It was the president who activated all the system.
Absolutely.
Minas Sheikh sir has joined, so we will take his comments from our first speaker.
शेख सर
Minas
काय
sir,
म्हणते?
Unmute yourself. Minas sir, unmute yourself.
Unmute करा sir, Minas sir. Minas sir, unmute करा. मीना सर अनम्यूट करा ना. Yes,
Unmute.
now speak.
Am I audible?
Yes,
Yes, sir.
yes, you are audible very
Yes, sir, very
clearly.
clear.
My apology at the outset for the technical hitches. At the outset, I must say Dr. Neha has presented very brief and to the point presentation. I don't have much to add, but just to revive, the God has been kind to us that He has given us a window to the brain right from at birth. And that window is very useful when the base is there up to 2 years of age. We know up to 2 years of age is very important. And since the God is kind and his way of being good to humanity, that window is used by we people. And as Neha has rightly elaborated, to see for the frontal. In fact, by default, most of the pediatrician, the moment, even if they're not in their clinic, if they say a child below 2 years, head will go to the frontal. And that's one thing. Having said that, coming back to the business, Neha has rightly talked about the frontal, anterior, posterior, their sizes, when to look at, how to look at. I will add only 2 points to it. One is the concept of raised intracranial pressure with the open fontanelle. Whenever you have CNS infections or CNS pathology, general perception is that an open OF will not have the raised intracranial pressure and effects on the brain. That concept is not right. Even if the AF is open and if there is a raised ICP, it has its effects, detrimental effects on the brain. So do not go by the concept that open AF will not give to raised ICP in a given child, because the child is up to 2 years of age. This is in addition to what we say for the signs of dehydration or meningitis and hydrocephalus and all that. So this is another clinical utility and applicability of the AF. Another important concept with regard to AF is, why, as I said in the beginning, the God has left us one window, and that window is used by the sonologist for the neurosonography. So in addition to that AF is very widely used for the neurosonography, and it leaves us, we may not be going for the its initial good neurosonography screening, leaving for us not to go for probably in all the cases for CT and MRI. So these are the 2 important concepts with regard to fontanelle. In addition to what Neha has said, I must congratulate the way Dr. Neha has prepared and presented the entire presentation. Thank you, and over to Rina.
Thank you. Thank you very much, sir, for the expert comment. Congratulations, Dr. Neha, for the wonderful presentation. Moving forward for our second speaker, she is from North Zone of the Maharashtra. I welcome Dr. Shraddha Ahira. She is working as a pediatrician and neonatologist at Sai Children Hospital, Chalisgaon, which comes under Jalgaon district. She is going to talk on antenatal steroid. I welcome you, Dr. Shraddha. Over to you. Thank you.
Hello, my topic is
your network is little slow. Slides are still not visible, but your voice is audible.
Please stop your video otherwise.
Yes, slides are visible now. Yes, slides are visible.
Slide visible, ma'am.
You can stop your video, ma'am. For the better presentation, just stop your video.
Where is this? Yes, ma'am. Okay.
Yeah, perfect.
Yes, ma'am. Please go ahead.
Introduction. Maternal hormones, specifically the glucocorticoid, enhances the surfactant maturation. Antenatal steroids modifies the surfactant readiness as well as the lung structures, including the thinning of the alveolar wall. Steroid stabilizes the circulation, so decreases the chances of NSC, ROP, so decreases the overall ventilatory support cost of drugs use betamethasone and dexamethasone. Betamethasone dexamethasone 6 mg, 4 doses 12 hours apart. Both the drugs are equally effective. Time to preterm previous weight loss due to the preterm delivery. Ideal time is between the 25 to 35 weeks. Complete course, baby is delivered after 24. After the 7 days, efficacy of the drug decreases. Repeat dose, if the baby is not delivered 15 days, next course of steroids can be administered, but then baby should be delivered in next 72 hours. Not more repeated courses are advised, as its advantages in the mother as a hyperglycemia, hypertension are not studied. And on the repeated doses are associated with poor neural development, cerebral palsy, and IUGR. Beyond 34 weeks, nowadays, antenatal steroid course is administered beyond 34 weeks and up to the 37 weeks, as the chances of respiratory distress syndrome decreases in the baby. Contraindication. No contraindication exist to the treatment, including rapidly progressive labor, and animal studies have demonstrated effect on the lung structure even after the incomplete dosing. Crude chorioamnitis is a contraindication. Take home message: steroid is beneficial in preterm labor between 25 and 30 weeks. Betamethasone is equally effective to the dexamethasone. Salvage therapy less than 35 weeks in a labor. And for those who have received that steroid and delivered after 7 days, then steroid should be administered. Steroid more than 34 weeks is optional for the cesarean delivery. Thank you.
Okay.
Hello.
Thank you, Shraddha ma'am.
Can I start?
Yes, sir, please.
Yeah. Shraddha, can you stop your sharing, please? Yeah. Thank you, Shraddha, for that brief the point presentation. I would just remind and recall what's important with regard to what is called as ACS, that is antenatal corticosteroids. This single intervention have been told to be effective with regard to good neonatal outcome with regard to its morbidity and mortality. And what actually ACS does? ACS reduces the incidence of respiratory distress syndrome. Not only it reduces the incidence of RDS, but it reduces the intraventricular hemorrhages, necrotizing enterocolitis, sepsis, and thereby reducing the mortality to the extent of 50%. And what is the effect on it? How it does? Actually, it does by your it leads to improvement in neonatal lung function by enhancing mitochondrial function in the lung architecture and by inducing lung enzymes. So basically, it affects on the lung by inducing lung enzymes involving in respiratory functions, involving respiratory mechanics. So this is what is the mechanism of action. And when to give, there are, if you go the literature, they have like staggered or they have separated like before 23 weeks, 23 weeks to 28 weeks, 28 weeks to 34 weeks, 34 weeks to 37 weeks. So these are the various times that one can give. However, the safest which has been practiced is 28 to 34 weeks. That's one. That does people do not practice for 28 weeks and after 34 weeks. There have been recommendations and guidelines for that. We'll look into it. So what are the steroids that's been given? Either betamethasone, that is 12 milligram intramuscular every 24 hours, or dexamethasone 6 milligram like intramuscular apart for 48 hours. What it means? Can we give hydrocortisone if dexa and beta not available? Yes, we can give.
Yes.
We can give hydrocortisone as much as 100 milligram intramuscular. Having said that, it is preferred to give betamethasone over dexamethasone. And what is the effect of timing or outcome? They say the actual effects, the betterment effects is between day 2 to day 7 of life. Like, once you give the steroid, the actual effects will be between day 2 to 7 days of life. After day 7, the effects weans off. That does not mean if you have given the dexa or betamethasone and the child is delivered in within 48 hours, it is not useful. It is useful, but the actual good effects come between day 2 to day 7 after given the steroids. Now, what are the effects on the child, the fetus, and what are the effects on the mother? Mother have some effects in terms of like transient hyperglycemia and the chorioamnitis and all those things, but the benefits outweigh the risk. That is why it is recommended. What happens to children? Children, there is some increase in the heart rate and all, but the fetus, but does not to the extent that it should cause worry. So all in all, ACS, that is antenatal corticosteroids, as I said in the beginning, is one single intervention which has changed dramatically the neonatal outcome, and it should be practiced, promoted, and preached. So thanks MahaIP for selecting this topic, and thanks to Shraddha having presented very well. Over to Dr. Reena.
Thank you. Thank you very much, sir, for the wonderful guidelines. Congratulations, Dr. Shraddha, for the good presentation. Moving forward to our next speaker, Dr. Poonam Mustard. She is from the west zone of the Maharashtra. Dr. Poonam has worked as a treasurer in an Academy of Pediatrics, Solapur branch in the year 2018. She has worked as a pediatrician in Ashwini Medical College, Kumbhari. Presently working as a pediatrician in Solapur Corporation and Max Multispecialty Hospital, Solapur. Dr. Poonam is going to talk on neonatal care. Over to you, Dr. Poonam. All the best.
Please share my slides, ma'am.
Poonam ma'am, kindly share your presentation. You are muted. Ma'am, we cannot hear you. Presentation is visible, but we cannot hear you. Kindly unmute yourself. Poonam ma'am.
मॅडम तुम्ही अनम्यूट करा ना त्यांना.
हो सर, रिक्वेस्ट टाकली मी त्यांना. पूनम मॅम प्लीज अनम्यूट करा स्वतःला. पूनम मॅम.
पूनम प्लीज अनम्यूट.
पूनम मॅम, can you hear us?
सोनाली मॅडम कॉल करा त्यांना जरा.
येस सर.
पूनम मॅम प्रेझेंटेशन दिसतंय, तुम्ही फक्त स्वतःला अनम्यूट करा. पूनम मॅम, can you hear us? हॅलो पूनम मॅम.
हॅलो
पूनम मॅम, ऐकू येतोय आमचा आवाज तुम्हाला?
हा मी केलंय आता. झालंय का?
आवाज येतोय डॉक्टर पूनम. या ऑडिबल.
Poonam
My
ma'am,
slides are visible.
just try to share your presentation, ma'am.
Yes, yes.
You are audible now. Just try to share your presentation.
Yes, ma'am.
तुम्ही आता बरोबर शेअर केलं होतं.
हो.
Just start it again. Yes, it is visible. Just make it slideshow.
Okay. Is it visible, ma'am? And am I audible?
Right.
Yes, yes, absolutely.
Yeah, sorry for inconvenience. Good evening, everyone. And first of all, I would like to thank Maha APN Women's Wing for giving me this opportunity to share my thoughts. So my topic is neonatal care. So why neonatal care is important? As we know, neonatal mortality is preventable in some conditions because birth asphyxia and neonatal sepsis. These are the two major causes of neonatal mortality. And we know neonatal period is a very critical period because there is a transition from placental circulation to neonatal circulation. And this transitional period is around 4 to 6 hours. So if we provide proper help at this period, then there will be successful transition and baby will be properly cared. So what are the components of the neonatal care? So first is immediate care at the time of birth, then thermal care, resuscitation if required, then support for feeding, infection prevention, nurturing care, assessment of any health problems if present, and timely referral. So before handling a baby or receiving baby, we should short and quick antenatal history should be taken. In that, you should ask for blood investigation, then ultrasonography reports, any drug intake, radiation exposure, or perceiving of fetal movements, then any maternal or obstetric, medical or obstetric complications during pregnancy, blood group of the mother, and if steroid has been received or not. In the intrapartum period, we should ask for the progression of labor, then any drug intake given to the mother, use of forceps or vacuum delivery. If required, if there is, should do assess, decide, and action. So first 60 seconds, that is first 1 minute. It is also called as golden minute. It is very much important. So as we know, this neonatal resuscitation is consisting of routine care, then positive pressure ventilation, endotracheal intubation, and drug administration. So it is the inverse pyramid actually. So drugs are used least, then endotracheal intubation, then positive pressure ventilation, and routine care. And Apgar score will help us. Then what is immediate care? So immediate care is when we receive the baby after cord clamping, then we should dry baby thoroughly. First, we should dry the head of the baby, then remove any wet linen from the baby. We can use the pre-warm clothes for a baby. Then stimulation. If there is somehow depressed baby is there, then we can stimulate the baby by just gentle rubbing of the back. Proper positioning should be given by keeping a roller gauge under the shoulder to keep the airway straight. It is also known as sniffing position. Then if the secretions are present, then suctioning should be done first in the mouth followed by the nose to prevent aspiration. Then you should look for any birth injuries present or any external congenital anomalies should there or not. Then assess the gestational age with the help of New Ballard score. If everything is okay, then give the baby to the mother. So this thermoneutral environment, this is the concept in which it is the range of environmental temperature at which the basal metabolic rate of the baby is minimum, the oxygen consumption is the least, and baby can maintain its normal growth and vital functions properly and maintain its body temperature. So it is again depending upon the gestational age and the birth weight, the ranges are different. So for a full-term normal newborn, it is 34 to 32 degrees Celsius from 0 to 30 days of life. So initially first 3 days it is 34 degrees Celsius, then 3 days to 3 weeks it is 33 degrees Celsius,
and after 3 weeks it is around 32 degrees Celsius. So we know warm chain concept. So warm chain concept is what? So delivery room temperature should be around 25 to 28 degrees Celsius. It should be free from the air draughts. Then warmer should be present if available. Then immediately dry the baby. Give for skin to skin contact with mother. Then start breastfeeding as early as possible. Postpone the first bathing of the newborn. Wrap the baby in warm clothes and rooming in with the mother. So this is the, as we know, APGAR score. APGAR stands for appearance, pulse, grimace, activity, and respiration. Then this is a flow chart of resuscitation. So as I have mentioned earlier, first 60 seconds, that is golden minute, is very important. Then thermal care. So what is thermal care? Thermal care, as we have seen, thermoneutral environment is important. So newborns are vulnerable to any temperature variations. So why this is so? Because they have large body surface area as compared to body mass. Then there is less fat and their skin is immature as compared to the adult, as well as the metabolic mechanisms. These are poorly developed, and there is 4 heat loss mechanism in newborn, as we can see in this diagram. So convection, then radiation, then conduction and evaporation. Then infection prevention. So as we have seen earlier, so neonatal sepsis, it is the important cause of neonatal mortality. So it can be prevented with the help of proper hand hygiene. Then cord care, when the cord is cut. So nowadays they have said that it should be, cord clamping should be delayed for around 30 to 60 seconds, that is around 1 minute, to improve the oxygenation of newborn. Then cord should be cut around 2 to 3 centimeter and it should be kept dry. Then proper eye care. So both eyes should be cleaned properly using 2 separate swabs from inner side to outer side. There is no need to application of either erythromycin ointment or silver nitrate drops. Then least handling of baby, avoid visitors. Our traditional practice of applying oil and kajal should not be there, and skin to skin contact should be there. Then keep the baby dry and gentle massage and bathing. So this nurturing care, this is a newer concept for nurturing care. It has 5 components. So good health, then adequate nutrition, safety and security, responsive caregiving, and early learning. So so good health means mother should be taught regarding what are the various health problems and when to go to show a pediatrician or a doctor. Then early treatment of any health problems if present. Adequate nutrition, it includes exclusive breastfeeding for first 6 months of life. Then responsive caregiving means mother should be very much gentle, stress-free, and gentle care should be given to the baby, and she should continuously talk with the baby. Eye-to-eye contact should be maintained. Safety and security, that baby should be kept warm, and proper hand hygiene should be maintained, and opportunities for early learning. So proper eye to eye contact should be maintained. This is important for early stimulation and proper neurodevelopmental brain growth in newborns. Then feeding. So breastfeeding, start breastfeeding as soon as possible. Then before going to the breastfeeding, you should first examine the breast. You should look for any breast problems if there. Then you should also tell mothers regarding the importance of breast milk, what are the components of breast milk. Then she should be given proper position for breastfeeding. Then what is proper latch is there. Then after feeding, she should be told about the proper burping. And after feeding, baby should be nursed in a supine position to prevent sudden infant death syndrome. Then after this, you should assess for any danger signs. You should also inform the mother regarding the danger signals. So excessive irritability, any feeding problems, then any color change or increased respiratory activity, lethargy, convulsions, this should be explained to the mother. And assessment should be done around 8 to 12 hourly in first 24 hours, then 48 hours, and at the time of discharge. Then immunization. So zero dose polio, then BCG and hepatitis B should be given at the time of birth. So what is the message for mother? So mother should be counseled regarding the feeding, then frequency around 8 to 10 feedings should be there. Then she should be taught regarding the proper position while breastfeeding, how to take care of baby, hand hygiene, then stool frequency. So mothers are most of the time complain that either there is excessive stool frequency or there is constipation. So both things are normal, because excessive stool frequency may be due to gastrocolic reflex. That should be explained to the mother. Then urine frequency. Again, mother are complaining that milk is not sufficient. So if baby is passing 6 to 8 times urine in a 24 hours, then the breastfeeding is sufficient. Then in our traditional practices, swaddling.
સબ્જી બે સ્વીટ બે નમકીન આમાં ચોઈસ મળી રહી છે ખાઓ આથી વધારે
Swaddling, our traditional practice of swaddling the baby is also important to keep the baby warm, but it should be depend on the comfort of the baby. And after feeding, baby should be there should be burping should be done to prevent either the colic or regurgitation. And mother should be told regarding the immunization. So this is a diagram to how to swaddle a baby. So according to me, take home message is that nurturing care is important. Mother should be properly trained regarding the feeding practices. What is the stool frequency? What is the urine frequency? Proper hygiene should be maintained. That's all. Thank you.
Okay. Dr. Poonam, can you stop your
Yes. Yes.
share screen share? Yeah.
Yes.
So thank you, Dr. Poonam. It was really good presentation. There were two components that you try to bring in. As has been the topic, that was neonatal care. So neonatal care, we all know that includes the preparation when the child newborn is about to be delivered, and the care after the first 28 days, that is neonatal period, and then the infancy. So our focus was to begin with more on the neonatal care, and you also to talk about the concept of ECNCD, that you talked about good health, adequate nutrition, responsive caregiving, safety, security, and opportunities of early learning. I think they are good. It's part of your ECNCD module that we have, that's been there up to at complete adolescent age. However, it has a component of the neonatal age also, which you try to bring in. That was good enough. Going back to the neonatal care, if you remember, we have been taught about what is called the essential care of newborn. So essential care of newborn is receiving the child in the safe environment. The environment consists of the infrastructure and the manpower. Nowadays, thanks to a lot of things, it's much better than what it used to be. However, one important message which I would like to share and request all of us to practice is at labor room, try to have Neopuff. That's T-piece resuscitator. Because if you have that, it is not very expensive, but it has very useful. Therein you can give then and there only the positive pressure ventilation without intubation if a child is required, like RDS. So try to have this something called as Neopuff, which is the standard of care these days. So that's one thing which I want to add on. In addition to what Dr. Poonam has talked about with regard to neonatal resuscitation, the thermoneutral environment, it's important. And majority of the newborn does not require active neonatal resuscitation, but some 1 to 2 or 3% may require. Accordingly, we should be ready for that. Important thing is delayed cord clamping, that we should actively promote. M first, come first, then N. That is suctioning mouth first, then nose. So remember, M come first, then N. And then important concept is about the feeding. We do everything right, but when we go to neonatal ward or in the mother's room, there has always been a dabba of milk in the best of setup. So it's our responsibility and duty to promote the exclusive breastfeeding till 6 months of age and the complementary feeding thereupon. Because we understand there are technicalities, there are some difficulties in that. We can balance between the two. Initial days, there is a less of breast milk, the colostrum is there. Remember, the colostrum quantity per day is hardly 40 to 60 ml per day, but it is enough. Why it is enough? We all know that the extracellular fluid volume of the newborn is on the higher side, and that particular fluid is sufficient to take care of the fluid requirement of the child for first 48 to 72 hours. Accordingly, what colostrum contains is what is required, but little less fluid. That's what is important. So whatever volume of colostrum is produced on day 1, day 2, and thereupon is very important. In fact, colostrum is the first vaccine. Believe me, colostrum contains everything what is in the blood except RBC. So that's very important to promote the breastfeeding in the best of setup. Even in our setup, we feel, we have to bring in lactation consultant. They have their own concept. The best person to teach is the neonate pediatrician himself. So that's what I want to stress upon, the essential care of newborn, breastfeeding. And I think rest, everything has been excellent and well presented by Dr. Poonam. Thank you, my all three presenters. They have worked hard to make it as simple and as easy to present to all of us. Thank you, Maharashtra IP, for providing us this opportunity. Over to Dr. Reena.
Thank you. Thank you very much, sir, for the wonderful guidelines for all three talks. We are really very fortunate to have you for these sessions. Congratulations, Dr. Poonam, for the wonderful presentation. For remaining three talks, I would like to invite my colleague, Dr. Swati, to conduct the further session. Dr. Swati, over to you.
Yeah, thank you, ma'am. On behalf of Maha IP, it is a pleasure to extend a warm welcome to everyone again. And this is second session, which will be consisting of 3 presentations, for which our expert will be Dr. Ganesh Kulkarni, sir. So moving to next presentation, our next speaker is from Amravati, Dr. Richa Joshi, madam. And her talk is on hand, foot, mouth disease. She is presently working as consultant pediatrician and neonatologist in a corporate hospital, Amravati. She has achieved first prize in International Conference of Neuropedicon held in UK for poster presentation, and she is advanced NRP instructor. So now I will request Dr. Richa madam to start her presentation.
Good evening, everyone. Thank you so much, ma'am. I would like to thank the Maharashtra IP Women's Committee for giving me the opportunity to share my presentation over this platform. As we all know, for the last few months, we have been seeing an increased incidence of hand-foot-mouth disease patients. So today's topic of discussion is hand-foot-mouth disease. So this was the disease which was first described in Toronto, Canada, and was caused by Coxsackie A16 virus. Since then, many serotypes of enteroviruses have been shown to cause hand-foot-mouth disease. It is a clinical syndrome which is characterized by an oral enanthemum, a macular, a maculopapular, or a vesicular rash. The most common serotypes responsible for it are Coxsackie A16 and enterovirus A71. The other Coxsackie A viruses and B viruses are also responsible. Basically, the increasing global incidence is related to the climatic conditions, so it is more seen in summer and early autumn. The incubation period is typically of 3 to 5 days, which may extend further to 7 to 10 days. The virus is shed in the feces up to 10 weeks and in the respiratory tract up to 30 days. The pathophysiology: once the enteroviruses enters either through the fecal or the oral route, it multiplies in the submucosal lymphoid tissue of the lower intestine, from where it disseminates to the regional lymph nodes and further to the reticuloendothelial tissues, further affecting the major organs. So in cases of HFMD, which are serious, major complications can be seen because of this. The transmission is basically by the feco-oral route, such like the person's saliva, fluid from the blisters, stool, sneezing or coughing, nasal secretion, or throat discharge. The prodromal symptoms, which are basically seen in the early phase, is loss of appetite, fatigue, runny nose, diarrhea, vomiting, and fever. The characteristic feature of hand-foot-mouth disease is eruption of a vesicular rash, which is usually seen 1 to 2 days after the fever, vesicles and pustules with an erythematous base seen on the tongue, buccal mucosa, hand, and foot, which will last for an average of 5 to 10 days. So basically, the characteristic of these lesions are they are usually non-pruritic and non-painful, but in cases of atypical HFMD, which is caused by Coxsackie A6 virus, it can be pruritic as well as painful. So two features can be seen. One is an exanthemum and the other is an oral enanthemum. The exanthemum can be a macular lesion, a vesicular, or an erosion with an erythematous halo, seen on the hands, feet, buttocks, and legs. While the oral enanthemum, it is basically seen on the anterior facial pillars like the tongue and the buccal mucosa and the soft and the hard palate. The hand-foot-mouth disease, which is caused by enterovirus 71, is basically responsible for central nervous system disease like the rhombencephalitis, acute flaccid paralysis, and aseptic meningitis, pulmonary edema, and hemorrhage. Atypical HFMD, which is caused by Coxsackie A6 virus, is responsible for high-grade fever, wider distribution, more extensive skin involvement, longer duration like for 12 days, palmar and plantar desquamation for 1 to 3 weeks after hand-foot-mouth disease, and nail dystrophy like the Bew lines, which are the transfer ridges on the nail, and shedding of the nail, that is the onchomedesis. This is seen usually 1 to 2 months after the disease has started. The diagnosis is usually made clinically, but when an etiologic confirmation is necessary, a nucleic acid amplification test can be done. A management is usually supported and is directive towards the relief of pain and adequate oral hydration because of the self-limiting nature of hand-foot-mouth disease. Admission and IV fluids may be required if the child is critically ill and not taking orally or has CNS or cardiac complications. Moving towards the differential diagnosis of hand-foot-mouth disease, the first one is varicella. In varicella, we will have lesions which will appear in crops, which are usually pruritic, and this will distinguish it from hand-foot-mouth. Second will be the papular urticaria, which is caused by an insect bite, which will usually arise at the site of an insect bite, and the buttocks, perianal, and axillary areas are usually spared. Third is primary herpetic gingivostomatitis, in which the oral lesion will usually consist of an erythema and edema of the gingiva with cluster of vesicles. They may even have a skin lesion, but that will usually be unilateral, which is herpetic vitreous. Fourth one is aphthous ulcers. These are very painful and shallow ulcerations with a grayish base. Then is herpingenia, which is a sudden onset of fever, sore throat, dysphagia, and painful lesion in the posterior pharynx. Then is erythema multiforme major, which has a characteristic bullseye appearance. You can see in the picture. And the last one is scabies. So scabies is usually seen in the finger web spaces of the wrist, elbow, and burrows are pathognomic of the disease. Prevention is basically hand hygiene, which is important. as for the prevention of community acquired hand, foot, mouth, surfaces should be clean, close contact should be avoided, and sharing should be avoided. Proper disposal of waste should be done. So the take-home message is, it's a viral illness, so there is no need of antibiotics. Parental counseling and reassurance is must because of the parents' anxiety. Hand hygiene is of utmost importance, and diagnosis is only clinical. Thank you.
Thank you, Dr. Richa, for a very concise and informative presentation. Now I will request Dr. Kulkarni sir to enlighten us for this topic.
Please stop sharing first.
Good evening. That has been a wonderful sharing presentation so far. Almost she has covered entire HMFD within 5 minutes of span. She has almost touched every part of HMFD. There is hardly anything to add to whatever she has presented, but yet I would try to put in a different way, is that we all know that nowadays these cases are coming in crops. Believe me, this disease is going to be as big as dengue, and this is as going to be big as flu in near future, because this particular disease is seen very rampantly in Chinese and Malaysian borders and in Singapore too. And near future, we are going to encounter with a lot of such cases. This is again a viral entity, which she has rightly said, and this comes in epidemics and outbreaks. The basic association with this particular disease is this comes with a temperate kind of environment, and it has an association with temperature more than 32 degrees. And it is said very well that once the temperature crosses more than 32 degrees centigrade, the crops of cases start coming up. And in our tropical or subtropical areas, this disease is almost kind of epidemic throughout the year. It comes in epidemics on and off. There's no uniformity as such. That's one thing. Now, these cases are said to be very milder cases, but should we really worry about them? Yes, we should. But when? So there are some red flag signs, I would say. If a child is drowsy, if child is running fever more than 3 days of time, if child is not improving after 10 days of time, if child is immunocompromised, if child is less than 6 months, probably these are the areas when we should, even though this is a hand, foot, mouth disease, which is said to be a very milder disease, we should be little wary, and we should in fact keep it in our mind that this child might deteriorate soon. Now, the second thing what I would want to put it here is there anything that we can prevent it? Yes, there is a vaccine to prevent it. This is not to be, thought of in Indian scenario, because we all are coming up with all milder cases. But in China, whatever they have found is the severity of this disease was much higher. As she rightly said, the etiological factors, enterovirus A71 and all other rest, Coxsackie viruses, Coxsackie A6, Coxsackie A10, Coxsackie A16. But out of all these etiological factors, enterovirus A71 is perhaps the most dreaded kind of virus, which causes HMFD, which has a severity. And the complications of this particular enterovirus A71 is like encephalitis, encephalomyelitis. In fact, it can also cause like AFPs, polio, like flaccid paralysis, like things. So this disease, though considered as a milder variety, it has a potential to cause complications, and it may in fact sometimes lead to death also. So what vaccines are available? The new vaccines, 2 different vaccines have come up into Chinese market. In fact, it has crossed phase 3 trials also. One is a monovalent vaccine, which is against enterovirus A71, and there is going to be a bivalent vaccine, which is going to cover up 2 serotypes. One is enterovirus A71, and the other is Coxsackie A16. So this is going to be a bivalent vaccine. Now, this monovalent vaccine is already there into the market. It has shown more than 95% of efficacy. The problem is, when they started giving this particular vaccine, this particular serotype, the enterovirus A71 serotype, went out of the demography, and the other serotypes started dominating. And that is why they are into kind of a fix now. We still are waiting for a bivalent vaccine in Chinese market. But for Indians perspective, I would say we are going to definitely have a vaccine, but not now, once we start encountering a lot of complications and severity of this disease. Now, the last part of it is the treatment. She said it is almost symptomatic, but I went on to check some systematic reviews and meta-analysis about treating these cases with some antiviral drugs. And one thing was found, which was very, in fact, astonishing, that was using acyclovir in HMFD. And what they have found is acyclovir had given almost good kind of symptomatic relief within 24 hours of starting this particular drug. I do not know, because mechanism of action is actually thymidine kinase inhibition in terms of acyclovir, which is a part and parcel of herpes virus. And this thymidine kinase enzyme is not available, not part of any kind of enterovirus or Coxsackie, but still it acts. Now, the exact mechanism of action is not known. Second drug of choice, which probably is very, coming up soon, is oseltamivir. And oseltamivir was used as an adjuvant along with ribavirin, along with betabarin and acyclovir together. So these are the two drugs, not in present front runners, but definitely to be considered if you have a case which is into a complicatory zone. Thank you so much.
Thank you, sir.
Over to you, Dr. Swati.
Yeah, thank you, sir. Very useful information, sir. You have shared with us, which is very useful nowadays because we have seen many cases are rising of HFMD. So now I will request our next speaker, Dr. Naval Sada, sir, for the next presentation. Sir is the practicing pediatrician at Karanja Lad since last 16 years and director of Vittal Children Hospital and Dental Clinic. And sir is a speaker at various social and pediatric platforms. So welcome, sir, and you can start with the presentation.
So good evening, everyone present here for the nice presentation. And first of all, I would like to thank MAHA-IP Women's Committee as well as all the judges and senior for giving me a chance to express my views. And the topic given to me is nebulization in pediatric practice. Though this topic is common and we are seeing many respiratory tract infection patients nowadays, and we are nebulizing almost every second or third patient in our day-to-day practice. So are we expert enough in nebulization? Maybe, but there are certain things one should know to improve the quality of drug delivery to the respiratory tract so that we can have an optimal effect of that medicine. So in next few slides, we will try to see how the process of nebulization, what is exactly the nebulization, how it works, what are the mechanism of action, what are the various medicines used, its doses, and what are the do's and don'ts in process of nebulization. So as we all know, what is nebulization? So it is a process of dispersing a liquid into microscopic particles, that is aerosols, and its delivery into lung as patient inhales through the nebulizer. As we all know, there are various different types of nebulizer. We just discussed this slide in somewhat detail. There are jet nebulizer, what we are using in day-to-day practice in our OPD, then ultrasonic nebulizer, and then inhaler, that is metered dose inhaler or a dry powdered inhalation. This jet nebulizer, they are not as much handy, but we are used this commonly, and it requires mainly a power source for its operating and otherwise oxygen inlet. But the drug delivery by jet nebulizer is not as much, because most of the drug delivered by nebulizer is wasted in either by mask or when the patient, what happens, this jet nebulizer releases aerosol throughout its process. When the patient is in phase of exhalation, that medicine gets wasted, and it is said that hardly 10 to 15% of the effective drug is delivered to the respiratory tract. But otherwise, its operating system is very handy. But about the ultrasonic nebulizer, this is portable, battery operated, very handy, and the drug delivery is very good. But it's said that the particle size of the drugs by ultrasonic nebulizer is almost around 3 to 5 micron. We will later see how the particle size affects the effect of drug. And the third is inhaler, that is metered dose inhaler or the dry powdered inhaler. As its name suggests, it exactly delivers the dose because it is having metering valve, and the doses required by MDI is very less. Now, how it works, just in simple language, I will try to explain this. In jet nebulizer or in any nebulizer, the more the pressure or more the flow rate of oxygen, greater will be the production of aerosol, and smaller will be the size of particles. And smaller the size of particle, more will be the delivery of that drugs till the alveoli, and greater will be the effect. So this, we see that jet nebulizer in this compressor convert liquid medications into the droplet of mist, and that droplets go into the respiratory tract, thereby causing its action rapidly. But in ultrasonic nebulizer, this aerosol or the mist is formed by hitting the solution by the ultrasonic waves. So what are the various indications of nebulizer? First, most important is the bronchodilation. So delivery of a bronchodilator drugs. Also to help expectoration if there are more of secretions or blockage. So in that we use mucolytic drugs or some concentrated saline to loosen that mucus and help to expectorate that secretions. Or in certain conditions, nebulization is used for the administration of antibiotics and antifungals in certain cases like cystic fibrosis. As such, there are no absolute contraindications for nebulization, but yes, if there is abnormality in heart rate, irritability in the heart rate like dysarrhythmia, tachycardia, or patient with unstable or increased BP, we have to consider this as a relative contraindication. Now, what we just discussed, the particle size. In this side, it is clearly shown that the particle size of 1 micron or less than 1 micron, it reaches up to the alveoli. And if the particle size of a nebulizer is 1 to 5 micron, it reaches beyond 10 generation of bronchi, but not up to the alveoli. And if the particle size is more than 5 micron, it reaches up to oropharynx, and it's hardly had any effect of the drug. So again, I will repeat that more the pressure or more the flow rate of oxygen at the reservoir input, more will be the aerosol and smaller will be the particle size, and more will be the effect of the drug. So particle size is that much important. What are the different medicines we use? We all know the bronchodilators like beta-2 agonists like salbutamol, L-salbutamol, salmeterol, formoterol. Anticholinergic drugs like ipratropium bromide, they act mainly by blocking the acetylcholine actions at its receptor site. Then anti-inflammatory like budesonides, and mucolytics like ambroxol, acetylcysteine, and concentrated saline. These drugs mainly used if the patient is having very thick secretions, because they loosen the secretion and help the patient to cough it out easily. We all know the doses of oral salbutamol. Systemic dose of oral salbutamol is 2 to 4 milligram. And see the dose of inhalation. Inhalation of salbutamol by nebulizer is it's 1.2 to 2.5 milligram, means half the dose of systemic dose. And while we see the dose of inhalation by MDI, it's 0.2 to 0.4 milligram, means almost 1/10 the dose of a systemic dose. Now we know the systemic dose of bronchodilator is having tremendous side effects. Means these side effects are even frightening to the relatives like tremors, insomnia, dizziness, headache. So we can curtail this side effect by using the nebulizer, or we can curtail this by using the meter dose inhaler. And that's why we should consider using nebulization over the systemic bronchodilators. These are the various different bronchodilators we use in day-to-day practice. We can use either plain bronchodilators or all in combination with anti-inflammatory drugs or hypertonic salines. In this one, I just want to mention this Duojet LD, not specific the brand, but I just want to highlight here the dose of levosalbutamol is even less. Means we consider 1.2 to 2.5, but here the dose of levosalbutamol is almost 0.6 to 5 milligram, means half the regular dose. This can all decrease the side effect of a systemic dose of oral salbutamol. So what are the various do's and don'ts while doing the nebulization? As we all know, to have an effective nebulization effect, we should have a proper position of the patient and a proper dose to give a desirous effect. Use of mouthpiece. Why? If the patient can hold mouthpiece firmly with the clenching in his teeth and causing tight closure by his lips, because there is less of wastage while using mask. Because during the mask, what happens, the most of the aerosols stick to the mouthpiece or the face mask, and there will be a wastage. So we should encourage this mouthpiece. We should encourage mouth breathing, particularly in patient if they are having rhinorrhea, sinusitis, nasal blockage, again to avoid those wastage. Proper size mask is of important, because even a loosely fitted mask, or if the mask is even half centimeter or 1 centimeter away from a face, then there will be no desired effect of that nebulization. Again, cleaning and sterilization as always, and we should advise nebulization when the patient is almost about to sleep. Even if the patient is having a nap at the afternoon or just at a bedtime to have a very desirous effect. As such, we should not nebulize any patient if he is having allergy to any component. We should avoid nebulizing in sleeping position. And this is all about the nebulization. Thank you. Thank you for patient listening.
Thank you, sir, for such a precise and practical presentation. Now I will request Kulkarni sir for enlightening us on this.
Thank you, Dr. Swati. Thank you, Naval. That was an excellent presentation. You almost covered every part of it. A few things to add on to, not as an expert point of view, but as an adjuvant to, who facilitates the things. So two more things to tell you about is basically now this nebulization, this particular word is being so criticized during last 2-3 years during this COVID pandemic. Whole world is against this nebulization, and nebulizers probably will be outdated very soon. That's what everyone, all respiratory societies have been telling us. So why is that happening? Let us get into the details. So instead of calling it nebulizer practices in pediatrics, I would rather put it aerosol medication practices in pediatrics. It becomes a broader terminology. Nebulizer just becomes a part and parcel of it. Every day now we see all our parents having nebulizer at home, and probably this particular home use of nebulizer probably will get outdated very soon. Why is that? I'll tell you. Because now when I say that this is aerosol medication practices, it comprises of so many devices. Even our humidifier becomes an aerosol medication device from which we can give moist oxygen to our kids. So that also becomes a drug delivery system. Second is nebulizer, which we have been using, and you rightly said that there are 4 different kinds of nebulizers. One is jet, one is mesh, one is ultrasonic. Amongst these 3-4 things, there are a lot of things which have come up is basically, accentuation, breathe accentuated, breathe coincidental, means, it matches with the breath and gives the nebulization. It accentuates the breath. So there are small volume jet. So there are a lot of different sub parts of this nebulizers have come up. Now the last one probably is the PMDIs, pressurized MDIs along with spacers, and the popular ones in adults is rotahalers. So these are different kind of delivery systems or delivery parts amongst the aerosol medication therapy. Now, which one to select? Is nebulizer worth enough, or should we be using PMDIs? So there are a lot of systematic reviews and meta-analysis have been done. 6 clinical trials, I could see almost 490 subjects were examined, and with these trials it was said that PMDIs are better than nebulization even in moderate to severe asthmas. The logic initially was, in moderate to severe asthmas, child will not be able to go for PMDIs, MDIs. So nebulizer was used. But these systematic review analysis told us that no, both are equal at par. They are almost, PMDIs have an edge over nebulization. But having said that, Cochrane also had its own review, and Cochrane said that no, they are all at par. They are all at par. But there are certain aspects about nebulization which is making it unpopular, is basically aerosols which are generated during the process of giving nebulization. So if a child is sitting in your OPD waiting hall and he is being nebulized, there is a chance that all viral aerosols are being sprayed to the other patients who are not in fact infected, and that there is a chance that cross infection could always be facilitated or droplet infections are sprayed. So that is why nebulizers are becoming less popular. Now, coming to few more things, like you said, indications of nebulization, the most popular indications for nebulization is basically all pulmonary diseases, wherein we have upper airway diseases, we have croup where we use racemic adrenaline or epinephrine to give it. We use moist O2 to all upper airway diseases. Then asthma, which very popularly we use nebulization, wherein we have bronchodilators, wherein we have ICS, corticosteroids, where we have actually mast cell stabilizers, mucolytics like ambroxol and acetylcysteine. But having said that, there are a few more uses of nebulization, and one of them is you would be amazed to see now a lot of antibiotics are coming into nebulization way of delivering. The most commonest is tobramycin solution inhaler nebulization, and this tobramycin nebulization is being used for treating chronic pseudomonas infections in cystic fibrosis. The second most common antibiotic which is being used through nebulization is colistin sulfate, and this is used for ventilator-associated pneumonias. So these are a few different uses. Then there is one more extrapulmonary use of nebulizer also. This is something which is very astonishing, and the most advanced uses for nebulizer through extrapulmonary part is basically gene therapy. They're using peptides, they are using this as a part of gene therapy to modify certain cancers for modifying this. Then they are using calcitonin in case of post-menopausal osteoporosis, calcitonin nebulization. They are using, in fact, insulin by nebulizer way, insulin nebulization to control diabetes. So these are different indications which are now coming up with nebulizer. But this is going to be a hospital-based nebulization practices. The home-based nebulization practices will vanish, and instead of nebulizers, probably PMDIs would take up its place, and that will go ahead. So this is how nebulization is coming up. There are still few societies like British Thoracic Society has said that you can very well use nebulizers. It does not really lead to viral spread of aerosols to other patients. So there are a lot of still controversies happening, but this is how nebulizer will definitely be at back front, and PMDIs, spacers and rotilers would take up a front seat henceforth in life. So this is all about. Thank you so much.
Ganesh, can I add one small comment with regard to nebulization?
Sure, sure.
Yes, sir, definitely.
Yeah, please. Well said by our speaker as well as Ganesh. My one request is to use nebulizer when in hospital. Deliver the nebulizer through oxygen port, not directly. That's the one important thing, because when you give nebulizer, especially in the patient who is like mild or moderate asthma, wherein you need some oxygen, give the nebulizer through oxygen port, central oxygen or whatever you can. We are in the practice of giving nebulizer directly from machine to port. So have the nebulizer through the oxygen port. That's my one of the requests.
Only problem with that is, Minaj, basically, the aerosol generation, it needs a lot of compressed or pressurized air. When we deliver it through oxygen chambers, it does not give us that much of pressure, or it does not compress air too, because everything depends upon the particle size, depends upon how much it is being, the liquid medication is being compressed. There is this one particular thing. Even I tried it in my ICUs, but hardly I could really, get along with that moist O2 through nebulizer. It did not deliver to that extent. That was a problem.
I agree with you, Ganesh. What your point is that you need a particular pressure to deliver the oxygen.
Yes.
However, it's a very important biomechanical or concept wherein when the oxygen is delivered in the central system, under what PSI, under what pressure it is been delivered. So there are, if you go and see back in the biomechanics, they have specific labels, the pressure level wherein the oxygen to be delivered. So low pressure oxygen delivery, moderate pressure oxygen delivery, and high pressure oxygen. This is what is been there in the individual.
Yes. No two doubts about it. If it has been used through that, I think that is going to be a wonderful addition. But all infrastructures are not so well equipped with it, So the problem remains there. And not to forget about good nebulization practices, pre-nebulization.
One of the another important thing with regard to nebulization, I must tell you the practicality is how to clean and how to sterilize nebulization.
Yes.
That point, I
frequent
think
hand washing. You should have a designated room for nebulization. Wherein only the patient and the nebulizer machine both are there, not the other patient sitting around. So a lot of things.
Yeah, so Naval, that you did very well, but I think this would have been practical issues which also can be discussed. How to clean, how to sterilize. It's mainly cleaning by the soap and water. That's sufficient. No need for sterilization. That's all. I think these are the few practical issues which I wanted to highlight. Otherwise, excellent presentation by Naval and great inputs by Ganesh. Over to you all.
Yeah. Thank you, sir. Thank you, Minash Sheikh sir and Dr. Ganesh Kulkarni sir, for your practical sharing your practical things with us on nebulization. So now we are moving to our last presentation of today's session, which is on emotional intelligence by Dr. Suchita Pofe ma'am. Madam is practicing pediatrician at Omega since last 25 years. Ma'am is having special interest in adolescent health and child nutrition. And ma'am is vice president of IIP Usmanabad. So welcome ma'am, and you can start with the presentation.
My presentation, is it visible on the screen?
Yes.
And am I audible? Am I audible?
Yes, ma'am.
Yes.
I'll start. In last 1 hour, we have almost touched the toes from the top up to the head and toes. So I am discussing about the next part, that is the mental health, that is equally important. And my next 5 minutes will be filled with emotions. Emotional intelligence, or it is called as emotional quotient also. Is it a fact or a fantasy? Or it is a just theory? Can it be implemented in our teens' day-to-day life? Check any newspaper, open any social site or any TV channel. News are filled with hatred, terror, suicides, road accidents, and murders. Are they related with emotions? Definitely yes. And what the definition is? EI is an ability to perceive, understand, and manage our own and others' emotion. That is by Daniel Goleman. And most experts agree that AI is a science because AI scores can predict measurable outcomes like in relationship, in career success, and life satisfaction. Unfortunately, studies show that only 8% of the adolescents are emotionally literate in India. Emotions are universal. They are part of our daily life. It has 3 parts: a subjective feeling. It may range from a simple thing like seeing a beautiful thing, you are a joyous in mood, and a major, like if you lose a loved one, you are in a depressed mood. So any anger, most of the times we are angry on our kids, on our staff, on our spouses. And anger, I think nowadays anger is the most prominent emotions we are facing. And second is the physiological response it evokes in us in the form of increased heart rate, respiratory rate, facial expressions change according to the emotional status. So in short, emotions are what we feel, thoughts are what we think, and behavior is what we do. The behavioral response is most important of all, the overt behavior in the physical form or abuse or verbal response. Teens are extremely volatile period of their life. Do emotions matter for them? Definitely yes. They affect the attention and learning. It has been found that teen with high EQ can concentrate better and are more academically successful. They can manage the relationship in positive way with family, friends, workplace, and school. Emotion impact on very life skills like decision making, coping with stress, and self-awareness. They help in communication of your needs and demands, and above all, and most important of all, is they enhance the empathy. We all, and particularly adolescents, have very high roller coaster ride of their emotions. We must have experienced it during our adolescence also. This is a very good model by Plutchik, the psychologist. There are 8 types of basic emotions, namely anger, fear, disgust, anticipation, joy, trust, sadness, and surprise. And they are exactly polar opposite of each other. Like joy is opposite to sad, fear and anger, anticipate and surprise, disgust and trust. When you look into details of this model, the emotions intensify from outside to inside. So when you are not happy with someone, when you are annoyed, you may go to the state of anger and rage. Last stage is rage. That is an extreme stage. Or like when you are in a pensive mood, you are not happy, then you go to the sadness and lastly grief. So lot more cases of violence, depression, suicidal tendencies can be handled at the second stage only, from going to annoyance to anger or to the rage or pensiveness. We have seen so many cases of violence in adolescents because they cannot control from annoyance to going to the rage stage. How you identify the people with low IQ, EQ and high EQ? There are many of us surrounding us, and it has been found, I'm not surprised with that females are better emotionally qualified, and all you must be agreeing with me also. Low EQ people, they easily misunderstood, they get upset easily, they always blame others for their failures, take no responsibilities, but they want favor all the times. They are less empathetic, argumentative, and problem creative. On the other hand, adolescents with high EQ understand people better, remain calm and composed. They are responsive, they handle the difficulties, they are empathetic. Can we develop the EQ? Yes. IQ is intelligent quotient is a nature's gift, but EQ can be nurtured. It is a learnable, achievable, and measurable skill. Remember just a simple mnemonic: be a ruler. R is recognize emotion in your unbiased manner. That means say that I'm angry, I'm happy, I'm joyous, I'm in a frustrated mood. Then understand them, how it is creating the response in you. Where you are going from one extreme to another extreme, label them, label your emotions, express them to your family members, your friends, with them. And lastly, most importantly, regulate them. Regulation is important. It can be taught to your adolescent that how to regulate emotions with the help of CBT and REBT, rational emotive behavior therapy. Definitely it can be taught to them, never to seek for instant gratification, never to go to any extreme. So Tuesday takeaway message is: make adolescent emotionally smart, not emotional, by setting an example by we adults, and assure them that a bright future awaits them if they are self-aware and self-regulatory. So EQ, my friends, EQ is a journey from well-being to well-becoming. Thank you.
Thank you so much, ma'am, for such an excellent presentation, which is full of emotions. Now I will request Kulkarni sir to give his emotional touch to this presentation.
Ganesh is very emotional now.
Ganesh is there?
Sir,
Ganesh sir, unmute kara.
Yes,
Unmute kara sir. Unmute kara.
पल्लवी मॅडम ते
Unmute करा.
करता येत नाही त्यांना, तुम्ही हे द्या, परमिशन द्या.
Pallavi madam.
Thank you,
Pallavi
thank you,
madam.
thank you, thank you. I was not able to unmute myself. I was not able to unmute myself. There was a problem, and that was because, you know, we all surrendered. What Sujata said is absolutely right. Women have highest EQ, we all surrender. Probably that's the EQ that what we have, we always surrender to them. That's one thing. Second thing is I'm fortunate here to comment upon. She's my batchmate, and I have seen her having the highest EQ and highest IQ together. So she's kind of a blend of a personality who has both poles together. So congratulations, Suchita. You have really presented. This is something which is, you know, very difficult to comment upon kind of presentation. So I'm not going to take too much of things. I have certain things which I have read today morning itself. So just what's more important in determining life success, whether to be a street smart person or a book smart person? So the answer to this particular question is, instead of focusing on a single general intelligence, the G factor, usually referred to as, some experts believe that ability to understand and express emotions can play an equal, if not more important role in however people to fare in their life. So it's not just a general intelligence, but it is, understanding and expressing your emotions is equally important. Second thing is, don't be under impression that if you have a best EQ, that means you are the most successful person on the earth. It is not that way. There is a potential pitfall to it. There are potential pitfalls, and one of those pitfalls, I'll tell you, a very high level of emotional skills can also have a problematic thing. So what are those problematic things? Research suggests that people with high emotional intelligence may actually be less creative and less innovative. So don't get happy that you are highest emotional quotient. Second is, highly emotionally intelligent people may have a hard time delivering negative feedback for fear of hurting other people's feeling. They always are bothered, if I say straight away on her face that you do not have this, you might get hurt. So this is the second pitfall. The third pitfall is little worrisome, and that pitfall is basically, research has found that high EQ can sometimes be used for manipulative and deceptive purposes. A person who thinks that he has a highest EQ, he tries to manipulate others. He tries to manipulate. So these are pitfalls along with, so what is the God's answer to these, with this comparison between IQ and EQ? Life success is a result of many factors. Both IQ and EQ play roles in overall success as well as health, wellness, and happiness. Rather than focusing on which factors have a more dominant influence, the greatest benefit may lie in learning to improve skills in multiple areas. So in addition to strengthening cognitive abilities such as memory and mental focus, you can also acquire and improve social and emotional skills. Now, the last question probably remains here. I would want to ask Suchita for that is, it has been said by some researchers that emotional intelligence can be learned and strengthened, but the others claim that no, it is an inborn characteristic. So what do you think about it? Is it really an inborn one, or can it be strengthened through manipulation, through acquiring experience?
It is a combination of both, Ganesh. It depends on the age, the personality type they have, the gender also already, and the customs, the family life they have suffered. It has definitely the influence, and so it is a nature as well as nurture also.
Great, that's great. Thank you so much.
Thank you, sir. Thank you for pearls of wisdom at the end of the session. And now I will request Dr. Amol Pawar, sir, to propose vote of thanks, because I can't see any question in the chat box, sir. So you can go ahead with vote of thanks, sir.
First of all, we will ask Dr. Gangulia sir to say a few words about this session today, after the speaker's presentation. Gangulia sir.
Thank you, Amol. It was wonderful presentation. Sarvani mast presentations केले, and we heard lot from the judges, this Dr. Ganesh Kulkarni sir as well as Dr. Meena Sheikh sir. Timely comments and proper comments. The last thing which I want to say is that the two words I got very good things: nature and nurture, as well as whether it can be acquired or not. But I still feel it is a destiny and luck which decides most of the times. Though we struggle hard and make the efforts, yes, efforts should be made, but probably it is the destiny and luck which plays the most important role. And for the emotional intelligence, the presentation was excellent, as well as other presentation was excellent. And at the last, I want to thank each and everyone to make this episode wonderful. All these episodes excellent ones, and heartfelt thanks to each one and all. And this MahaIP platform is yours platform. And always, please do come with some innovative ideas. These all innovative ideas at the start of the tenure only, I appealed to most of them, come with this idea. And this idea came forward from our chairman and co-chairman of MahaIP committee, and it was wonderfully done. All efforts taken by them. So I see lots of talents across the Maharashtra state, young and upcoming things, which if given opportunity, will do the wonder for the Maharashtra Academy. And I think so they should come forward and that's the way to go ahead, I think so. Thank you very much, Amol.
थँक्यू गोगले सर. पुढील वर्षात पण हे सर्व प्रोग्राम्स असेच कंटिन्यू चालू ठेवू आणि प्रत्येक महिन्यामध्ये अशा वेगवेगळ्या ऍक्टिव्हिटीज आपण अशा चालू ठेवू आणि तुमचं मार्गदर्शन त्यासाठी नेहमी होत राहणार. मी सर्वप्रथम डॉक्टर गणेश कुलकर्णी सर, I thank Dr. Ganesh Kulkarni sir, Dr. Meena Sheikh sir. In spite of their busy schedule, they have agreed to come on this dais as an expert and guiding in preparation to all the speakers about their presentation, about their topic. त्यांनी अतिशय चांगली मेहनत घेतली आणि ते आज आपल्याला सर्वांना दिसलंच की म्हणजे जवळजवळ प्रत्येक प्रेझेंटेशन अतिशय चांगल्या सुटसुटीत शब्दात आणि सुटसुटीत रचना केली होती पीपीटीची सर्व स्पीकर्सने. मी डॉक्टर नेहा सिंग जी एडिटर आहे, जी जसं गंगोले सर म्हणतात माझा राईट हँड अमोल, लेफ्ट हँड जय भांडारकर सर, तसं माझा राईट हँड नेहा सिंग आणि लेफ्ट हँड विशाल राऊत. तर अशी ही नेहा ऑलराऊंडर, तिने पण अतिशय चांगल्या याच्यात प्रेझेंटेशन दिलं. नंतर डॉक्टर श्रद्धा अय्यरराव, डॉक्टर पूनम मस्तूर, डॉक्टर रिचा जोशी, डॉक्टर नवल सारडा, यंग डायनामिक नवल सारडा सरांनी अतिशय चांगल्या शब्दात नेबुलायझेशन किंवा एरोसोल थेरपीवर आपल्याला मार्गदर्शन केलं. नंतर इमोशनल इंटेलिजन्सवर डॉक्टर सुचेता मॅडम, ज्या गणेश कुलकर्णी सरांच्या बॅचमेट आहेत, हे पण आपल्याला म्हणजे बऱ्याच जणांना पहिल्यांदा कळालं की त्यांनी अतिशय चांगल्या शब्दात सर्व इमोशनल इंटेलिजन्सवर सर्वांना मार्गदर्शन केलं आणि त्यासाठी त्यांना गाईड करण्यासाठी सरांना आज पुस्तक वाचावे लागले. सर इज व्हेरी अकॅडमिशियन आणि सरांचा हा टॉपिक म्हणजे सरांच्या येस 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 मॅडम,
तिची मला युजी पासून भीती वाटते.
बाकी मी सर्व महाआयपी वुमन कमिटीचे जे पॅट्रॉन्स आहेत, चेअरपर्सन, को चेअरपर्सन आणि झोनल मेंबर्स, जे झोनल कोऑर्डिनेटर आहे, त्यांनी अतिशय 9 महिन्यामध्ये सर्व स्पीकर्सला शोधून देण्यात जी मेहनत घेतली, जी टॅलेंट त्यांनी पूर्ण 9 महिन्यात 954 स्पीकर्स नवीन यंग, त्याच्यातले जवळजवळ मी तर म्हणेल 40 ते 42 स्पीकर्स हे फर्स्ट टाइम महाआयपी प्लॅटफॉर्मवर किंवा महाआयपीच्या कॉन्फरन्सेस मध्ये फर्स्ट टाइम ते आले असतील. तर असे सर्व त्यांनी शोधून काढले एक एक करून. म्हणजे प्रत्येक महाराष्ट्र आयपीच्या ब्रँचेसच्या जे ओबीज आहेत, प्रेसिडेंट, सेक्रेटरी, ट्रेझरर यांची मदत घेऊन त्यांनी हे टॅलेंट शोधून काढले. तर मी पूर्ण महाराष्ट्राच्या आयपीच्या जे ओबीज आहेत, प्रेसिडेंट, सेक्रेटरी, ट्रेझरर, त्यांचेही या कामी मदत केल्याबद्दल मी त्यांना धन्यवाद देतो. बाकी सर्व डिजिटल टीम, पल्लवी मॅडमने, डॉक्टर विशाल राऊत, पीडियाट्रिशियन असून हा मनुष्य कुठे कुठेपर्यंत नेतो ते पूर्ण 9 महिन्यामध्ये आपण फ्लायर बघितले असतील तर ते एका पीडियाट्रिशियनने बनवलंय. हे म्हणजे पूर्ण सेंट्रल आयपीच्या ज्या ब्रँचेस आहेत तिथं असा व्यक्ती सापडणार नाही. आणि ही रायगड आयपीची जी म्हणजे रायगड आयपीचे हे जे रत्नजडीत हिरे आहेत, एक एक हिरे आपण यावर्षी आपल्याला ते बघायला मिळाले आणि खरंच ते पुढेही आपल्याला तशीच मदत करत राहतील. तर मी सर्व डेलिगेटचे आभार मानतो. एमएमसी ऑब्झर्वर जे आज जॉईन होऊ शकले नाही त्यांचे पण आभार मानतो. आणि पूर्ण 9 महिन्यामध्ये जी प्रचंड एमएमसी पॉइंट्सच्या निमित्ताने का होईना आपल्याला दर एपिसोडला जवळजवळ मोर दॅन 200-300 डेलिगेट्स लाभले. आणि पोस्ट सेशन लिंक सुद्धा जवळजवळ प्रत्येक व्हिडिओजला, प्रत्येक युट्यूबवरच्या या ट्यूजडे टेकच्या सेशनला मिनिमम 800, मोर दॅन 800 आपल्याला व्ह्युअरशिप लाभली आहे. आणि त्याच्याने आपले महाआयपीचे, फेसबुकचे, युट्यूबचे जे सबस्क्रायबर आहेत ते पण जवळजवळ आता 4,000-3,500 पर्यंत पोहोचले आहेत. तर मी सर्व महाआयपीच्या मेंबर्सचे, महाआयपीचे मी आभार मानतो. आणि जाता जाता एक्सपर्टचे विशेष आभार मानून
डॉक्टर अमोल, अजून एक गोष्ट, प्रत्येकाने आपापल्या ग्रुपमध्ये आपलं पोस्ट करा आणि हे सर्वांनी महाआयपी युट्यूब चॅनल सबस्क्राईब करावं, शिवाय फेसबुकवरती टॅग करावं, जेणेकरून सर्वांना ते आपल्याला चांगलं सबस्क्रायबर्स मिळतील.
येस, फेसबुकवर पण आपलं पेजचं आपल्या अकाउंटचं नाव आहे महा-IIP आणि युट्यूबवर पण आपलं पेजचं नाव आहे महा-IIP. आता 3400 समथिंग 3480च्या पुढे गेले सबस्क्रायबर आणि जवळजवळ फेसबुक फ्रेंड्स आपले आता आपण केरळच्या पुढे जाऊन आपण आता इंडियामध्ये 2 नंबरला आहे. म्हणजे सेंट्रल IIP नंतर आता फेसबुक फ्रेंड्स लिस्ट मध्ये पण आपण जवळजवळ 3900 पर्यंत पोहोचलो आहे. तर त्याबद्दलही मी सर्व जे रिपोर्टिंग ग्रुप आहे आपला फेसबुक साठी जे पल्लवी मॅडम नेहाने मदत केली तर त्यांचे मी त्याबद्दल आभार मानतो.
अजून एक गोष्ट
कार्यक्रम
अजून एक गोष्ट अमोल, आपलं IIP वेबसाईट महा-IIP वेबसाईट पण फ्रेंडली झालेली आहे. ऍपच्या मार्फत ते अवेलेबल आहे. ते ऍप मध्ये टाईप केलं महा-IIP ऍप तुम्ही बघू शकता आणि ते थोडंसं अजून त्याची अपडेटिंग प्रोसेस चालू आहे, पण ऑलमोस्ट इट हॅज बीन डन आणि खूप डायनेमिक त्याचा अपकमिंग इव्हेंट पण दाखवतं. ते बऱ्याच काही गोष्टी चेंजेस केल्या. वन कॅन ऍक्सेस द वेबसाईट ऑल्सो आणि ऍपला ऍक्सेस करणं इझी असतं. वेबसाईट आम्ही आपल्या पुढे जाऊन तर हे ऍप पण अवेलेबल आहे, तर कोणी सर्वांनी डाउनलोड करून घ्यावे आपल्या मोबाईलमध्ये.
हा, प्रत्येक मेंबर त्या वेबसाईटला ऍक्सेस करू शकतो महा-IIPच्या. आपले जे मेंबरचे डिटेल आहेत तर ते आपण त्यावर बघू शकतो. आताच कमेंट बॉक्समध्ये एक विशेष सूचना आलेली आहे आणि सेंट्रल IIPचे इलेक्शन चालू आहेत. तर मी महाराष्ट्रातल्या ऍज अ सेक्रेटरी जनरल म्हणून महाराष्ट्रातल्या प्रत्येक महा-IIPNला विनंती करतो की ज्यांचं अजून कोणाचं वोटिंग करण्याचं राहिलं असेल तर त्यांनी प्लीज आपल्या या डेमोक्रेसी प्रोसेसमध्ये वोटिंग प्रोसेसमध्ये सामील व्हा आणि 100% वोटिंग करण्याचा आपल्या ब्रँचेस मधून प्रयत्न करा. तर आजचा एपिसोड संपला. मी गंगोले सरांना विचारून आजचा एपिसोड संपला असे जाहीर करतो आणि सर्वांना